Hey everyone, welcome to the Cannabis and Driving webinar. I'm Paul Maver, a pharmacist from Health House. We've had a massive amount of interest in this subject, and hopefully some of what we're talking about tonight can be used to bring about change in the current laws. Australia is on track in 2020 to have up to 80,000 medical cannabis approvals, and this is shaping up to be a really big issue. So tonight we have 5 panelists who I'll introduce shortly. Each will give a short presentation, and then we'll have panel style questions at the end. So if you have any questions, please don't use the chat function, but submit your questions during the Q&A. We'll try to get through as many as possible at the end of the presentations. So from the outset, I want to say we're not here to promote dangerous driving or driving whilst impaired. Patients should absolutely not get behind the wheel if they're at all affected by cannabis or any other substance. And as always, if you're considering medical cannabis as a treatment option, please consult your healthcare professional. So tonight's discussion centres around a sensible change to current laws to allow medical patients who are on low-dose THC and are not impaired the ability to drive in the same way as they may do with other prescription medications. And for instance, those on a sleeping tablet, such as temazepam or other benzodiazepines, may have a really good night's sleep. By the morning, they're well rested, they're non-drowsy, non-impaired, and may be safe to drive. And may be safer to drive than if they weren't medicated. A lot of cannabis patients are given microdoses of THC, which achieve a pharmacological effect without impairment. And in the same way, a very small amount of alcohol may be safe to drive. And there's trace amounts of alcohol in everyday things like cough medicines, lemon lime bitters, and even stir fry contains soy sauce, which contains a small amount of alcohol, as my kids were proud to point out to me. Now, another major issue we're facing in relation to cannabis road testing is in Australia, we have 6 states and 2 territories, and each have different laws pertaining to drug driving. So there's no one jurisdiction that covers them all. And unlike alcohol, which is water soluble and can be metabolized and cleared from the body relatively quickly, THC is fat soluble and can be detected in the body for up to 2 months. The roadside saliva tests, I'm told, are inaccurate and cost more than $100 per test. They only detect yes or no to the presence of THC rather than a level in the case of alcohol. In technical terms, they are qualitative, not quantitative. And as you may have heard, Victoria has recently moved to change their laws early next year. They're looking at treating medical cannabis the same way as other prescription medications. And this is really good news, and we hope the rest of Australia follows suit. Now, enough of me. Let's start with our speaker presentations.
Hi, my name is David Holburn, and thank you for the opportunity to speak in this webinar. I was a magistrate for 21 years, and prior to that I was a defence lawyer, mainly in the area of drug law. I wrote a book on drug law as a consumer guide, and also I've got the leading cases on drug driving law in New South Wales. I dealt with literally thousands of people coming before me over the last 6 years for drug driving offences in New South Wales. The vast majority of those were using for medicinal purposes, and a minority, but a significant minority, were following the directions of their doctor, either by prescription or otherwise. I wanted to just open with a few comments to dispel some myths about drug driving and drug driving laws. Firstly, I get asked all the time, well, if I keep a prescription in my glove box, won't that save me from the effect of these laws? Well, the answer is no. It won't save you from the effect of these laws. There is no current defence to drug driving detection laws to say, well, I've got a prescription. Any level that is detectable of THC in your system will lead to prosecution, loss of licence, arrest, suspension of licence, and the like. I should stress, of course, that pure CBD, if you can get that on prescription, is safe in terms of the drug driving laws, But of course, that doesn't work for many people. And most people who get prescriptions for cannabis get prescriptions for substances that contain THC. And of course, if they then go and utilise the black market, then they're certainly getting material with THC in it. The second myth is that the testing is random. It's not random. Number plate recognition is so advanced now that the police can be driving down the highway and a little alert goes off in their car, and that car has somehow either previously been involved in a drug driving incident or is, because of some intelligence or some information, is a suspicious motor vehicle, bang, they pull it over. And of course, we all know that surrounding festivals, music festivals, hemp festivals, the police target those that they think they're more likely to succeed to get an arrest rate. After all, it's far easier to be going sitting outside a festival than it is searching people inside a festival. The third myth is that this has to do with affectation. It doesn't. Nobody is seriously suggesting with 5 or 10 nanograms of THC in your system that your driving is adversely affected. And indeed, the many thousands of people I dealt with, not once was it alleged that the person was showing signs of affectation, because if they were, they would be charged with a separate offence of driving under the influence. The fourth myth is that this is a road safety measure. It's not. If it was a road safety measure, we would have seen a massive reduction in the road toll. This is not a road safety measure. This is a prohibition. This is a prohibition aim, and it has a prohibition effect. The next myth is that there is a degree of compatibility between a cannabis medicinal industry and the current drug driving laws. I don't think the two can sit together. I just don't believe you can have a successful medicinal cannabis industry or medicinal cannabis practice while you have the drug laws as they are. I mean, really, what you're going to be saying to every single person who's using anything other than pure CBD oil, sorry, you can't drive. Now, for rural and regional Australians, that means no access to their jobs, that means no access to their doctors. It's an impossibility for the vast majority of people to be without their licence. And I can't see how the industry can succeed long term with any substantial number of people involved while these silly drug driving laws are in place. Final myth I want to deal with is that you don't get a criminal record. Of course, you get a traffic record, you get a police record. In some states, you get a criminal record, but no matter what you call it, you will have to declare this in terms of insurance, in terms of travel, in terms of employment, that you have a drug-related offence. Whether you just get a ticket for it and that's a suspension, or you go to court and you get fined and disqualified, you still have a police record. It's still on the court computer. It's still on your traffic record. And in many states, it is in fact on your criminal record. I wanted to finally just talk a little bit about the consequences of these laws from a legal point of view. The first consequence, obviously, is that a huge bucket of road safety dollars that should be used on guardrails and education campaigns and the like is being spent on drug driving detection. A lot of court time is spent on this, and it's just plain silly. The second real consequence of this is all these people losing their licences. Thousands and thousands of people around Australia are losing their licences every year because of this law. In New South Wales, up to, my estimate, somewhere between 10 and 12,000 this year will lose their licence as a result of this. And don't think for a minute that you can count on going to court and keeping your licence, because in New South Wales, at least, the vast majority of people will actually not go to court. Their licence will be suspended on the spot, and only if they elect to go to court, which takes 5 or 6 weeks anyway, will they get there. And even if they get there, only about 1 in 3 people charged with a drug driving offence who get to court leave without a conviction and a subsequent loss of licence. So don't rely on the courts. Parliament and the police and the regulations all seek to bypass the court as much as possible and inflict immediate loss of licence. Of course, the other consequence of this is that people are changing from illicit drugs to prescription drugs. People are changing from cannabis to alcohol. And as a result of that, people are simply not getting the best care according to their doctors. I guess there's some winners in this, and that is the pharmaceutical industry and the alcohol industry, but there's a lot of losers as well. I'd like to see the law changed. I'd like to see drug driving detection laws completely wiped. If you're driving while affected, if you're driving under the influence, then those laws have always been there, and they should still be there. But there is absolutely no need for these drug driving detection laws in their current form. At the very least, those with a prescription should have a defence. And that defence should simply be, if you have a prescription, then if you're still driving under the influence, if you're weaving all over the road and can't walk a straight line and the rest of it, well, fine, you lose your licence. But in terms of detectable levels, a prescription should be a complete defence to any charge. And people shouldn't have their licence suspended while waiting to go to court. So that's the big change I'd like to see straight away, leading to a complete re-evaluation and abolition of drug driving detection laws. Thanks for your time.
Hey everybody, I'm Rhys Cohen, I'm a cannabis consultant, and I want to talk to you about the politics of random roadside drug tests and how it relates to medical cannabis. So look, if you're watching this talk, you're probably already reasonably aware of the known issues with testing for the presence of THC at the roadside, right? The tests are inaccurate, they're insensitive, and they can't prove impairment, which you would assume is what the police and the government are most concerned about. The reason why these testing programs have been massively expanded over the last few years, despite both government and police knowing about these issues with their methodology, is that it's relatively easy to say, yeah, okay, well, we know they're not accurate, sensitive, and they don't test for impairment, but people shouldn't use drugs. People shouldn't be smoking pot. It's illegal, and therefore the whatever punishment they receive is justified, even if the punishment is disproportionate or misapplied. So that's sort of the ethical justification that props up this random roadside drug testing regime. One of the other reasons why the government and the police really love random roadside drug tests as a policy framework is because they are a quick and easy way to generate hardcore statistical figures about the police are doing their job. They are easily reportable figures. Went from 100,000 a couple of years ago to 200,000 in 2020. We're putting more effort in, and ministers and police chiefs can come out and say, look at us, we're doing good work, we're keeping the community safe because we keep testing more and more people at the roadside for drugs, and we keep finding them. So something must be working. The reason why medical cannabis is the perfect tool to use to dismantle this regime is because it totally undercuts the moral argument on which this program is based. Right? The moral argument is it's an illegal drug, shouldn't be doing it anyway, it doesn't matter that we can't prove that you're impaired, it doesn't matter that the tests are insensitive, you're probably smoking weed, and that's a bad thing. But obviously with a medical cannabis patient, a legally prescribed medical cannabis patient, they are someone with a medical condition who's been treated by a doctor, and they've been prescribed a medicine, they've got it from a pharmacist, and just like every other drug, they are entitled to take it as their doctor recommends, and to not drive if they feel drowsy. So this is why we've only more recently seen a chink in the armor of the mobile drug testing, or random roadside drug testing regime, is because the ethical argument that underpins it is being subverted because of the legalization of medical cannabis and the increasing numbers of people who are now being prescribed medical cannabis. Now, this is an important thing to appreciate, I think, politically, because I think the first argument that we should be making is that anyone who's legally prescribed a cannabis medicine should be allowed to drive so long as they're not impaired. and they should be entitled to a legal defense like everyone else is. It's a very reasonable argument to make. It's already showing great success in Victoria, and I hope it'll translate here in Australia. What that does is, once it does go through, for example, in Victoria, it proves that the government has acknowledged that people who test positive for THC randomly are often not impaired, or that there is no way for the government or the police to prove that they are impaired at the time of driving. We already appreciate this, and tacitly it's understood that that's already the case. But any changes to this legislation would formalize the fact that these tests don't test for impairment, and give a lot of ammunition to drug law reformists who want to fundamentally change the way in which random roadside drug tests are conducted in Australia. So I think that the first argument that we should be making as a community is that legally prescribed medical cannabis patients should be allowed to drive so long as they're not impaired. Regardless of what we think or feel about random roadside drug testing overall, or about the illegality of cannabis overall, I think if we start with that one argument and we make it really well, that provides a solid ethical and legal foundation with which to work on broader issues. So look, that's a quick overview of some of my thoughts about the politics of random roadside drug testing and how it relates to medical cannabis. And I look forward to chatting with you all and hearing your thoughts.
Thank you very much, Reece. So we're going to be moving on to next speaker, which is Dr. Alastair Vickery. Just one moment.
Hi there, I'm Alastair Vickery. I'm the Medical Director of Myria, a health data technology company. We run a number of specialised clinics for looking after patients and prescribing medicinal cannabis. And we measure in a standardised way at R-grade level, the sort of data from people to determine what works in whom and when. We've got 4 clinics across Australia, in New South Wales, Victoria and WA. We've seen over 2,500 patients in the last 18 months for over 54 therapeutic indications. And that means that we have a lot of data and we have a lot of experience in medicinal cannabis. So sort of the classic patient that we see, chronic non-cancer pain, who's failed conventional therapy, who is taking a suite of opiates. And what you can see is at the bottom here, the results where people will get to cease their opiates, it's opiate sparing. They often finish their Lyrica and PEA, and they still get an improvement in pain and depression, anxiety and stress. And we can follow patients showing our cohort versus this current patient has been with us for a long time and show some extraordinary results. So in terms of driving, it's a very big issue for us because, as you know, Australia has a zero tolerance law for driving under the influence. And there is, because it's a lipid soluble molecule, there is no safe dose to avoid detection, particularly by blood, in a major traffic accident. And then on top of that, we know that the combination of THC and CBD together, mostly in a balanced drug, is the most efficacious for neuropathic chronic non-cancer pain, insomnia, and a number of other indications. Interesting looking at the crash data, although many people have about 30% of motor vehicle fatalities have concomitant cannabis in their blood, mostly it is in association with co-taken substances like alcohol, methamphetamine, and THC being the most common together. But that's also with other medications, opiates, benzos, and amitriptyline. While in Canada, it's actually legal to drive if you have a substance, as long as you are not drug impaired while you're driving, and they perform a standardized field sobriety test, which is essentially walking a white line, balancing on one leg, and being assessed for horizontal nystagmus. If you fail that test, then you can be taken for blood tests for THC and other substances. And they have drawn a line at 5 nanograms per mil or 2.5 nanograms per mil with a blood alcohol of 0.05. So at Emerald Clinics, all of our patients sign a medical consent to take THC, and that consent includes the prohibition on driving. I guess in summary, there are about 3 types of patients. There are those that aren't driving because of their disability, those who choose to cease driving because someone else can drive, and those who take the risk. That risk is probably small, and we'll discuss that in detail about urine tests and blood tests. But it's this problem of prohibition for even small amounts is a major impost to good quality evidence-driven care, that is prescribing THC substances for patients to improve their condition. And there's even, and I'm sure Cam is going to talk about this, a lot of confusion even with CBD-only products, pardon me, and crossover. So I suppose the solutions are the CBD-only prescriptions and prohibiting the prescription of THC, and I don't think that is good quality care. Changing the legislation, and in Victoria, that legislation is before the Parliament, and Fiona Patten has been championing that for the last 5 years. And then there's policy changes within the police force, and this is some of the discussions that we're having with our police in WA regarding how they enforce those policies. And I think perhaps they are issues that we can address tonight. So Amelia, there's our website and my email address. I'll be happy to take questions. Many thanks.
Good evening, everyone. My name is Thomas Arkell. I'm a researcher with the Lambert Initiative for Cannabinoid Therapeutics at the University of Sydney. And right now, I'm just going to give you a brief overview of some of the research that we've recently run, looking at how cannabis affects driving performance. So a couple of key questions that we had going into this research, things that are largely unanswered in the cannabis and driving literature, but things that we think are quite important to address. So firstly, what is the magnitude and duration of driving impairment produced by cannabis? So we know that cannabis doesn't exactly improve driving, but there's quite a lot of uncertainty around the magnitude and the duration of these effects at the moment. Does CBD reduce the impairing effects of THC? So are there any differences between cannabis containing high levels of CBD compared with cannabis containing high THC but no CBD? And how accurate are the devices that are used for roadside drug testing? So the Securitech Drug White and the Drug Test 5000, which are the 2 devices used in New South Wales and in some other Australian jurisdictions. So in this study that I'm going to just briefly describe the results from, we had a number of healthy volunteers come into our lab on 3 separate occasions. And over those 3 separate occasions, we gave them either cannabis containing high levels of THC, but no CBD, so high THC or THC dominant product, equal amounts of THC and CBD, so a 1-to-1 product, and placebo cannabis. And we're really interested in whether there are any differences in the impairing effects of cannabis, depending on the CBD content. So this gives you an idea of what our driving simulation tasks look like, which is how we measure driving performance. So we have participants complete this twice in each session at 30 minutes when they were most stoned and when we thought that the impairing effects of cannabis would be greatest, and then again at 3.5 hours, when people tend to not really feel stoned anymore, and when we would have expected that the impairing effects of cannabis would have largely been off. So what do we find? Well, Contrary to what we were expecting to find, we found that people were impaired at both 30 minutes and at 3.5 hours after vaping. So this suggests that cannabis can impair driving for up to 3.5 to 4 hours after use, after smoking and vaporization. The level of driving impairment that we saw was similar to the effects of alcohol at a BAC of 0.05%. So the level of driving impairment that we saw was certainly not extreme, but also wasn't totally negligible. Third, CBD did not reduce the impairing effects of THC. So we saw similar levels of driving impairment in both conditions. So regardless of whether people received cannabis containing just THC and no CBD, or whether they received cannabis containing equal amounts of CBD and THC. And fourth, we saw some false positives and false negatives with both roadside drug testing devices. So these are cases where the drug test should have come back positive, but it actually came back negative. And conversely, where it should have come back negative, but it actually came back positive. So how does this apply to medical cannabis users in Australia? Well, it's important to realise that cannabis can impair driving for up to 4 hours after use, even if you may not feel impaired. Second, that cannabis containing both THC and CBD may cause similar levels of impairment to cannabis containing THC only. And third, that THC can be detected in saliva for some time after use, even if the driver is not impaired. Now, of course, there's some limitations to the study that we ran. So firstly, we just use healthy volunteers. So these are people using cannabis occasionally, up to twice a week. So moving forward, I think it's going to be really important for us to expand this research to look at medical cannabis patients. So we don't yet know, there hasn't been any research yet looking at driving performance in medical cannabis patients. So it may be the patients who are using their own medical cannabis, who are familiar with its effects and who have been using it for some time, show less impairment than what we saw here in this study involving healthy volunteers. So there's a number of unknowns, things that we hope to address in future research with the Lambda Initiative. This is a very brief overview. I'll look forward to the Q&A afterwards, and I'll be very happy to answer any questions that you may have about our research. Thank you, and I'll see you soon.
Hi everyone, and thanks so much for having me this evening, and I look forward to contributing on this really challenging topic around cannabis and driving. My name's Cameron Scadding. I'm the CEO of Source Certain International, which is headquartered here in Perth, Western Australia, and so a shout out to everybody joining along online, and thank you very much for taking the time. Source Certain International has participated in the sector, the cannabis sector here in Australia since its inception. So we do a whole range of different testing services. We've developed new cannabis final dose forms, and most recently, and a highlight for me, we've supported the peak industry body MCAA in building out its code of conduct. My job tonight, though, is quite specific, and what I'm going to try and do is provide a bit of a basis for the discussion which we will have later as a panel. And in order to do that, I thought I'd step us through a bit of a wrap around the country and the different types of testing that's in place, but also provide some insights into potentially where there's opportunity to make some changes. In order to do this, I'm going to step us through a short presentation. I just might make this full screen so that you can see it. And hopefully you can see this at home. So what I'm going to do today is I'm going to step us through each of the states and what is done today, the types of testing that is done, and some statistics. What I'm keen to encourage people to do here is to consider this through the lens of a few questions. Most of these samples are collected without cause, which is an unusual situation from a forensic evidence perspective. But the backdrop of this conversation is obviously road safety. So we need to be respectful of that, and I don't think there will be any argument around keeping that road safe. The spectrum of illicit substances available to users is extensive, right? And we don't test for all of them. You know, why not? And what is the decision-making process there? Cannabis is now legal for medical use, and so it's really important that we find a way to provide confidence to people that need to access this medicine. And it starts with conversations like this. I'm not going to step through all of this because there's a lot of information here, so I'm going to share the PowerPoint during the session today. The figure at the top provides you with an indication as to the approach. So what is the threshold? So it's a zero tolerance approach in all jurisdictions. It's clear though that each state does make decisions around the types of things that it tests roadside for. It should be noted that all states test roadside for cannabis. There'll be some discussion, I'm sure, around accuracy of these tests. It's really important to acknowledge that all states do a secondary confirmation, of which one of these confirmations is done in a laboratory. Generally, there is some similarities throughout. There's some sort of presumptive test or a rapid test roadside. There can be often a secondary test done roadside, but often in a bus or a police station. And then there's a confirmation test. I'm not going to step through each of the examples here because you can read these, but it shows you the different approaches in each of the states. The remainder of the states listed here, I think probably the key difference is if there's a positive in the Northern Territory, there's actually a blood test taken. So what are the types of tests that are done? At a sort of summary level, without getting into the detail of how these things work, they all use a rapid immuno-based assay approach. So there's some chemicals that are on these sort of wipes that you can see here that effectively react and become measurable when there are the active compounds present. So in this case, THC. Two of the most common examples is the Draeger units, which are often in the bus, and then SecureTech, which I'm not picking on because they are definitely fit for purpose, but the SecureTech, which are used roadside. The accuracy does vary, but like I said, almost all of them will go for further confirmation testing. So what are the stats? So 500,000 drugs roadside tests were taken in 2019, of which 10% were positive. But have a look at WA. I mean, we've ramped up very quickly to doing over or nominally 40,000 roadside tests a year. I picked WA here because we have the longest history. And then just to circle back to the backdrop of this conversation, and we need to find a way to enable patients to access cannabis without the threat of losing their license. But it's important that we acknowledge that there is a backdrop of road safety here, of which that graph on the left there shows a reduction in road deaths with increasing drug tests. I'm not saying that's necessarily correlation, but that is what the numbers are. Thank you very much for taking the time to join us tonight, and I look forward to contributing to the panel further today.
I'm on a mission to help change the medical cannabis and driving laws Australia-wide. To do this, I've teamed up with a group of patient-led organisations, educators, industry bodies and cannabis experts to form a group called Cannabis Law Reform Alliance. We are running a campaign to help make drug driving law changes medical cannabis patients need. Our campaign is called Drive Change. Our campaign will launch over the next couple of months, and we'll be calling for equal rights for medical cannabis patients. We'd love your help to take this message from grassroots to the highest levels of government. If you believe in equal driving rights for all patients, please join us and help us drive change. Whether you're a patient, you work in industry, or know someone who needs medical cannabis and is affected by this law, please join our campaign by going to honolulu.com.au/drivechange.
Hi everyone, I'm Dunya. I'm one of the other pharmacists here that works at Health House, and I'd like to now invite all the panelists to bring up their videos and sound before we go through a couple of questions. So feel free for the viewers to add in any questions as we go and use that question and answer function at the bottom of your screen rather than chatting about it. So my first question is going to be quite vague, but very important and kind of links back to what you just mentioned, David, in terms of what do you all think we should change and what will drive it? So I'll start with you, David, if you want to just chat about that.
Well, I think the numbers are going to drive change. There's 200,000 tests in New South Wales this year. Of those, probably from the stats we just saw, about 10% will test positive, and that's 20,000 people losing their licenses every year. The vast majority of those will be those who are using cannabis for medicinal purposes. That just can't continue. I think the public outcry about that will be so great. I think also the cannabis industry has a real role to play here. There's a lot of money in the cannabis industry, medicinal cannabis industry, and if it's going to take off, then that money will talk, and the industry, I would have thought, has a big, strong, vested interest in encouraging change. Finally, I think that the other reason there will be change, and I'm hopeful, is that unlike other road safety measures, we've seen no reduction in the death toll or injury toll. So, with random breath testing or seat belts or airbags or changes to 50-kilometre limits, we saw a massive reduction in road trauma. With this experiment, and that's really what it is, of increasing drug driving testing, we're not seeing a reduction in the road toll. There's nothing like the mass reduction that we saw with each of those measures. And I think the public will be sick of spending road safety dollars on such an ineffective, unfair measure. So I think there is momentum for change for those reasons, and I think things are going to start moving, hopefully quickly.
Definitely, yeah. Go, Reese.
Yeah, I mean, thanks for all your contributions, by the way, everybody. I thought that was really snappy and captivating. So thanks for that. I have to respectfully disagree with you there, David. I don't think that, and it seems to me to be obvious that neither the police nor the government really care about the fact that these tests don't prove or demonstrate impairment. Otherwise, they wouldn't have ramped them up so quickly, knowing the issues that these tests have. I think what will move the needle here is when legally prescribed medical cannabis patients who aren't impaired do test positive for THC and are dragged through the courts. I think that is going to be that is the issue that's going to actually cause or contribute to change. I mean, you look at any other kind of drug law reform initiative, in New South Wales or other states, clearly evidence, concern for public health, a desire for positive outcomes are not things that motivate drug policy. But bad news stories about medical cannabis patients losing their license do.
Yeah, definitely makes a good point with that. What do you all think about possibly if a trial would be possible within states as well, with recording that impairment and whether that actually happens with medicinal type of cannabis? Maybe Dr. Vickery, you might have a perspective definitely from a prescriber point of view.
Oh, you're still muted there, Alistair.
Okay.
Thanks, Tanya. You muted me as well, did you? Yeah, I mean, we need decent trials, but we need someone to fund it. I think that what is missing is the cannabis industry, that they don't seem to have any interest in pushing this forward. We actually need, we're seeing, 1,500 patients a year. We have the substrate. We just need the funding to be able to do it. Lambert, Tom have been doing a fair bit of work in this area. Are you doing simulation trials?
We are, and we've just actually completed a non-road driving study as well, where we're looking at real-world highway driving, and we're under strict instructions, I'm afraid, to keep that data under wraps for a little bit longer. But in the next month or so, we will be publishing some very interesting data in this area that I think will be of enormous relevance to this. And I think moving forward, this is a conversation we've been having repeatedly, is that we do need to start looking at medical cannabis patients. Like I mentioned in my talk, all of our research to date, and really all of the cannabis driving research to date, has involved healthy volunteers. These aren't patients. And it may well be that the results that we've seen previously don't apply in quite the same way to medical cannabis patients. So I think that's a real research priority, and we're certainly aware of that. And that's something that we're looking to be involved in.
Yeah, and I think clearly that the problem, as David outlined, is that it's about impairment, or it should be about impairment to drive, and it's not. That both the police and the government are very keen to have strict cutoffs, which are actually not reasonable in terms of even alcohol. That 0.05 in a seasoned drinker who's been sitting nursing pints all day is quite different to 0.05 in an 18-year-old or a 16-year-old who've just started drinking for the first time. And it's also related, as is clear in the fatality statistics, that it's about polypharmacy or lots of drugs that although cannabis is found in about a third of fatalities, alcohol is the most common, but the combination of alcohol, methamphetamine, and cannabis is the most common. And that's in our patients, and you're quite right, Tom, that in our patients, they're taking opiates and antidepressants and benzodiazepines, and then they're taking cannabis. And so the combination of all of those is actually what causes impairment. So we actually need to be measuring drivers' impairment. And that's indeed what they've done in Canada, that they have a sobriety test that they do at the roadside, which is only a little bit more sophisticated than walking a white line, but it is still allowing a judgment of sobriety. And if you are thought to be under the influence, then you are then taken for a drug test, and we then measure levels. And they have levels of 0.25 nanograms per litre plus a blood alcohol of 0.05. And I think that's very sensible. And it would be nice if Australian law and Australian policy could reflect what is more sensible in terms of a small amount of alcohol, a small amount of benzos, a small amount of opiates is actually a hell of a lot worse than 0.05 of alcohol, let alone the disability of those people driving.
Absolutely. I guess I had more of a question as well for Cameron, possibly. This is more specific to Victoria, but the question was, do police in Victoria have autonomy to decide whether to charge a driver who's tested positive for THC? Can they choose to just check for impairment as well?
I'm not a police officer, but I've worked with them most of my career. Most of them do have an element of discretion. I think that's probably less than it was 15 years ago, where you could kind of have that conversation with the copper on the roadside. My conversations with police on this is they're not interested in catching someone taking medical cannabis. We've got quite a blunt, and I think this is David's argument, we've got a really blunt instrument here that's being used around a strategy of road safety, but also tangled up in illicit drugs and a broader, issue around prohibition. And so when you talk to police, like I said, they're not interested in catching, a 70-year-old that's taking THC for pain. In fact, I think most would understand that 70-year-old who slept properly is probably going to be a better driver than one that hasn't, for example. So I don't believe that they're in it for this, but their autonomy is definitely less than what it used to be. And most people will have been through one of these sort of booze bust type situations. It's a machine, right? It's a swipe. It's either positive or it's not. If it's positive, you're in the bus. There's not a lot of talking in that conversation, And so, I think whilst the idea of discretion is sort of a romantic one, I don't think there's a lot of opportunity there. But I wouldn't blame the police either.
Yeah, and discretion is not a desirable pressure release valve for these kinds of policies, right? Because we've seen, in New South Wales, there was reporting early this year by The Guardian that showed police have discretion to charge someone or not for simple possession of cannabis. They can choose in the moment to allow someone to go to a drug court or to take another route. And half the time, if you're your average person, 50% of the time you'll get let off effectively, and half the time you get sent to the courts, unless you're black, of course, unless you're Indigenous, in which case over 80% of the time you will be forced to the courts by the police. So, relying on police discretion sounds nice, depending on who you are. Like, I'm not going to get in trouble, I'll be fine, but it's not me I'm worried about necessarily, right?
Yeah, lots of factors for them to consider. I had a question from a couple of viewers, actually, more to do with, I guess, the testing of cannabis and half-life. And I was going to introduce Ian as well from Lambert Initiative, teamed up with Tom to join us tonight. So thank you so much. My question was more in terms of what sort of half-life or elimination is usual with, have you found medicinal cannabis in your research? I guess specifically they want to know, after smoking a joint, would you fail a roadside test?
The short answer to that is there is no answer. And I know that's what no one wants to hear, but there's no clear time window in which cannabises will be detected or not detected in your oral fluid. THC is very messy. Normally, if you smoke or vaporize cannabis, you get a very large amount of THC straight away, within a couple of minutes of smoking. By half an hour, by an hour, that's decreased enormously, and then it keeps decreasing after that. But it depends on a lot of factors. It depends on the individual. It depends on how much saliva you have, the pH of your saliva, what you might have eaten recently. And there is just no sort of blanket rule that says after 6 hours, after 8 hours, that you're likely to test negative. We found that by 3 to 4 hours, most people did test negative in our research, but that was with one particular dose and the two types of cannabis that I mentioned in my talk. So it's possible, with higher doses or with other types of cannabis that window may be longer. With oral products, so if you're not smoking or vaporizing cannabis, it can stick around for quite a bit longer. So it's a very complicated issue, and I think it's become quite widely accepted now that there is no clear or sort of easy to interpret rule here. It's not like alcohol, where you can say after consuming X amount of standard drinks that you'll have a BAC of 0 in X amount of hours. We can't do that with cannabis.
Yeah, I agree with that, especially when patients do ask pharmacists, even in the community, about, is this safe to take and drive tomorrow? And specifically, someone did ask you actually what dose of medicinal cannabis was used and shown to be equivalent to that 0.05 blood alcohol level in the driving simulation test. Do you remember?
Again, there's no equivalent to a blood alcohol level. The dose we gave was 13.75 milligrams of THC. So it's a modest dose. It's not a huge dose, but it's also not a negligible dose either. But it's very hard to, to say that that's equal to a certain blood alcohol level.
Absolutely, yeah. Everyone's elimination is different.
Exactly, and it really depends how you use it. How it's absorbed and eliminated depends enormously on how you've consumed it. Smoked or vaporized roots produce very different patterns to what you see with oral cannabis.
Yeah.
I had an interesting question as well from Suzanne in terms of what the difference between police testing kits is and the ones that patients can purchase from chemists, if anyone.
The ones you can purchase in the chemist are not the same ones the police are using. That's the short answer. You can't actually buy the one the police are using. So there are two devices. The first device, the Securitech drug wipe, at least in New South Wales, The police use a particular version of that device that's not commercially available. So we've done some testing with an equivalent version of the device. This one tests for a few more drugs instead of the 3-panel one the police are using now. But I think really, if you're going into a chemist and buying a drug test, it's probably a urine test. I'm not sure how easy it is to buy an oral fluid test, and certainly not the one that police are using. It's not available.
The actual technology behind it, though, are almost all the same. So, yeah, I think probably the cheaper it is, the less reliable I would generally say it is too. As a general rule.
I think it would be fair to say that, like, if you feel like you need to buy a drug test to check if you will or will not pass a random roadside drug test, you probably shouldn't drive. If you're concerned about testing positive at the roadside.
Yeah, and it's a very, very valid point. There's a big difference between these rapid tests that are used on a urine versus those that are actually used roadside. Although the technology behind them is similar, that it's quite a different kind of outcome. So,
yeah, I guess to touch on that, Cameron, I think you wanted to maybe talk about the accuracy of testing and what you have found. Tom did mention devices as well in his research.
Yeah, and I mean, I'm not sure how many people have done a literature search on this. I mean, there's quite a lot out and about with respect to what the accuracy of these is. And you know, the guys at Lambert can probably land on some sort of number too. It depends a lot on the target on these particular devices, but it can range from 10 to 20%. What is important to note, though, is it's not just about tests that are falsely positive. It can be falsely negative too. And so whilst, I mean, I think there's a discussion to be had about accuracy, the solution doesn't sit in here. I would generally argue that the tests the police are using from a rapid detection perspective are fit for purpose. They then safeguard kind of in terms of someone getting in trouble that shouldn't by doing a secondary test, often a different type of test roadside, and then it's almost always sent to the lab for confirmation. So you know, yes, there are issues, and you know, Alistair mentioned an example which we've certainly come across with him where it's clear that one of the rapid tests on the urine side was clearly delivering a false positive because of some sort of very high cannabis or CBD dosage that was happening. So there are definitely issues here. Again, the solution doesn't sit in this part of the debate though, because like I said, I think that they're largely fit for purpose.
Yeah. Has anyone found any statistics to provide insight into the proportion of people who test positive for cannabis and who have had a script for medicinal cannabis?
Yeah, so we've been hunting for, I mean, that's a really good question. And I'm interested to go back to Dave because I mean, there was some sort of numbers thrown around there as part of, you know, the numbers that are likely to be medical cannabis. I mean, from all of the hunting around that we've done and the conversations we've had with law enforcement around the country, we haven't been able to get any sort of indication as to the number. And I've had one individual contact us who had an initial issue of which the matter was dropped. So I don't want to say it's not a problem either, because we still need to deal with it, because it's not so much about the fact that the police maybe aren't taking these forward. There's still a broad issue around confidence between the doctor, patient, and their ability to drive. And so we still need to get clear about a solution here. But it's certainly not the issue. It's not playing out how it certainly is talked about, I guess, is probably the comment I'd make. And I mean, Reese and David, I mean, you guys are living in the world. Alistair, you guys are living in this world too. I mean, you know, how many examples are you sort of hearing?
It's interesting. I've been, as many people have been, since 2016, keeping our ears to the ground for someone who gets done at a random roadside drug test, who was only taking prescribed medical cannabis which contributed to their true positive result. So there's been a very small handful of those that I'm personally aware of over the last few years. I think it's true to say, Cameron, you're 100% correct, that there aren't thousands and thousands of legally prescribed medical cannabis patients getting done at RBTs at the moment, which is a good thing. I think there's a couple of reasons for that. First of all, patient access has sucked for such a long time that basically no one's been able to get it until, in the last sort of 12 months or so. So it's an issue that everyone knew was going to be a big one, given enough time. And I think now we're getting to the order, the level of patient access that's required for it to actually be a social problem that people have to pay attention to. And the second one is patients who need to drive or want to drive badly enough will have that conversation with their doctor and will avoid taking a medicine that precludes them from driving. I don't know how many people I've spoken to who said, yeah, I've got the fibromyalgia or, I've got the cancer pain and I want to take medical cannabis because I think it can help me, but I need to drive to the shops and back. So I've taken the CBD instead. And, I'm still in pain. I'm still nauseous, whatever. So I think it's certainly unclear. Like the level to which this is affecting people. But what is certain is that it's only going to continue being a bigger and bigger issue with every year that goes by. I mean, on one hand, you've got patient access that's growing at a near exponential rate. And on the other hand, you've got the ongoing commitment by police forces around the country to keep increasing, in some cases doubling every year, the number of random roadside drug tests that are conducted. So at some point, they've got to meet, and then then there'll be a reckoning,
My experience in court was that every week, at least one person would hand up a prescription, at least. Further, as we all know, it's incredibly expensive. It's not on the PBS. So there's many people who go and get a prescription and then will top up using Hemp Embassy or any of the other sources through Compassionate Friends or the like. There's Lizzie Haslam estimates there's 1 to 200,000 people using illicit medicinal cannabis. So I don't really see that there's a lot who have prescriptions who aren't filling those prescriptions from the chemist. But I myself and Matt Hanley are acting for a person charged in Victoria currently who is on a prescription who is busted. Now, there is a huge incentive not to come forward and make yourself the poster boy or girl for this cause. And that is obviously there is still a bad publicity rap. If you're a glazier or a builder or a truck driver and you are employed and you have been caught using medicinal cannabis, well, you're not gonna say, hey, look at me. So I think there's a significant hidden problem and not so hidden problem for those reasons. That this is nothing new. On the north coast of New South Wales, there are many doctors who've been suggesting and seeing the rewards of non-prescription cannabis for many years. I think also the other factor that's really key to look at is the average age of those appearing in court for this charge. What I was not seeing was 18-year-old party animals or doof goers charged with cannabis driving offences. They were largely, and I think it's something maybe the Lambert Institute could look at, they largely middle-aged long-term users. And what is the distinction between medicinal and habitual and recreational use for those people who are having a joint every night to go to sleep? So in some ways, I think getting caught up in the medicinal, non-medicinal, recreational, habitual, etc. Dichotomy, more than dichotomy, is not a useful conversation. We should be looking at what is the harm in these people driving with 5 nanograms or 10 nanograms of cannabis in their system, and the answer is no harm.
Yeah, very good points as well. I will have to wrap it up, and I'm really annoyed because there's so many good questions listed. But if you have any further ones, feel free to email Health House as well, and we'll try and get through some. One final one, though, I guess if you can answer this in a sentence or two, how the viewers can have a voice to push for change for these drug driving laws in each state. What would be your advice?
Call your local MP. and email them and tell them that you're angry.
Go to the Honolulu website and look up Drive Safe. I think there's going to be a really significant publicity campaign and social media campaign coming up.
Beautiful. It's been really insightful tonight, coming from the angle of doctors to consultants, from the law to research. So I really want to thank everyone for joining us tonight, and I hope that each panelist has learned something as well. But we'll have to wrap it up now, and we have recorded this webinar as well. So we'll send out a link to all the viewers, and it will be on YouTube. And thank you again for joining us, and I hope you all have a good night.
Thanks very much.